प्रेजेंट करेंगे डॉक्टर इसे माता सर. सो प्लीज वेलकम सर, डॉक्टर इसे माता सर.
हाथ नहीं उठता है.
Our colleagues, I am delighted to be here. I am surrounded by a galaxy of learned doctors of the world. So today's topic, management of ethics, is a very old topic. Nothing new here. It's just like a get together. There were so slides. I will skip so many unimportant slides. I will deal only. So you know. Symptoms of mucosal damage which are produced by the abnormal reflux of gastric contents, which contains mainly acid, into esophagus. This causes esophagitis. Classical symptom is frequent and persistent heartburn. It also creates heartburn to the treating physician also. डॉक्टर कहता दवा की आपको आराम ही नहीं हो रहा. You are prescribing proper PPI 2 times daily. 80 milligram pantoprazole have come in the market. So many antacids are adding into that. A great burning sensation for the patient also. Very difficult to treat the patient. 7% of Indians complain of the symptoms of daily symptoms. Daily होता है आपको आराम नहीं हो रहा है. He is moving from doctor to doctor, changing the physician frequently. So this is the also they have told me that some PG students will come. So this is for the PG students that is also transport food from mouth to stomach through peristaltic momentary contraction of the esophagus. Lower esophageal sphincter LES, in short I will describe it around the LES. This relaxes on swallowing food to allow food to enter stomach and then contracts and prevent the reflex. तो एलियस very important thing. एलियस में हम लोग कुछ करना है उसके contraction और उसके pressure को. So normally in some cases you see that some amount of reflux occurs multiple times a daily. This is a transient relaxation of the earliest. Known as. It is not associated with swallowing. Earliest response with the swallowing of the food, but sometimes without swallowing, this transient relaxation of earliest occurs, and this also irritates the food from the stomach into the esophagus. So, basic structure, you know that this is the most important culprit, lower esophageal sphincter here. So how this occurs? So the three defense mechanisms in the esophagus and the GERD in the areas, which should be protected. So this impairment of three defense factors must be considered. That this impairment causes this GERD. Alias barrier impairment, I have told you already. Relaxation of alias, low resting alias pressure, increased gastric pressure also. When take large amount of food, the distension of the stomach, and also for decreased clearance of the reflux material from esophagus to the stomach, and decreased esophageal mucosal resistance also. These are the pathogenesis of GERD. There are so many contributing factors, not only this. I mentioned three things that will be helpful in the treatment management of GERD. So decreased alias pressure also occurs after eating chocolate, taking alcohol, taking fatty meals, coffee, cola, tea, garlic, onion, smoking. Very important. The substances which cause direct irritation to the gastric mucosa, tomato-based products, that is processed tomato, coffee, spicy foods, citrus juices, medicine, non-steroidal anti-inflammatory drugs, you know already, aspirin, iron, also potassium chloride, stimulates acid secretion. soda, beer, smoking. Other contributing factors which causes decrease in LDL pressure, alpha blockers, anticholinergic agents, TCA antihistamine, beta adrenergic agonist, calcium channel blockers, diazepam, dopamine, mepridine, nitrates, and other vasodilators, estrogen, progesterone, oral contraceptive, prostaglandins, and theophylline. These are the decreased LDL pressure. Lines of defense. क्या क्या precaution defense है जो लेंगे कि this will be GERD should be prevented. Clearance of reflux material from esophagus, very essential. Primary peristalsis from swelling, increased salivary flow. Secondary peristalsis from esophageal distension and gravitational effect also. Very important is esophageal mucosal resistance. Mucus production in esophagus occurs, which saves the esophagus mucous membrane from damage. Bicarbonate movement from the blood to the mucus also helps in the GERD. But how this is caused? GERD is caused. Amount of esophageal damage, you see, it depends upon composition of the reflux material. It worse acid or alkali may be reflux material. Volume of reflux material, quantity depends upon small or large. Natural sensitivity of esophageal mucosa and rate of gastric time. Typical symptoms must be people encountering the patient with heartburn, belching, regurgitation, hypersalivation. हाइपरसलाइवेशन मुंह में लार बहुत आता है, पेशेंट को कोई कंप्लेन नहीं बोलेगा, बहुत सलाइवेशन होता है, बहुत सलाइवेशन होता है. हाइपरसलाइवेशन में भी एपिसोडिक और नॉक्टर्नल, रात में ज्यादा होता है बोलेगा. This may be aggravated by meals and in reclining position. सुनिए समझिए. Atypical symptoms. Sometimes patient complains of that should be considered clinically very efficiently. Non-allergic asthma, chronic cough, process of voice, laryngitis, the chest pain, very confusing for the physician. This resembles just like the angina pectoris. Sometimes the primary physician in the village area is Mrs. gastric हो गया है, ऐसा दवाई दे दिया, पेंटोप्राजोल इंजेक्शन दे दिया, कुछ दे दिया. That should be differentiated. Chest pain should be taken very seriously. It may be angina, patient dies of that. जब तक रेफर करके आपको बताएगा, patient develops acute coronary syndrome, patient may die immediately. And maybe only symptom omeprazole test. It is very important test to differentiate this GERD with chest pain, non-associated chest pain, angina pectoris. Omeprazole test, I will not go into detail. This is omeprazole is given the high dose for short period of time. And symptoms is taken weekly, 2 weekly, by increasing in higher dosage, 80 milligram, 160 milligram. Whatever you use, the dose will be triple or double. It's very important to differentiate between GERD and non-associated chest pain. If he is not treated properly, the patient may develop so many complications like esophagitis, esophageal stricture and ulcers, hemorrhage in the form of hematemesis, or when we go into the lower melena, perforation occurs, aspirated into the lung, and aspiration pneumonia can develop. Development of Barrett's esophagus, continuous in contact with the acid and this stomachal tract. The colonal epithelium is changed, and this may in the later on develop into the esophageal carcinoma, silent killer. So many our great physicians have died of that. the barrage esophagus, they ignored and developed esophageal carcinoma. The changes in the epithelial lining of the esophagus should be considered very conscious by endoscopy or by biopsy should be taken. Should not be taken. And precipitation of an asthmatic attack also occurs. कैसे ट्रीटमेंट करेंगे? बहुत दूर जवान से कर रहे हैं. हमारा गोल क्या है? The goal of our treatment. First of all, to eliminate the symptoms. कलेजा में दर्द है, यहाँ दर्द होता है, जलन होता है. सिम्टम आपको रिलीव करना है, तो रिलीव करना है. फर्स्ट ऑफ ऑल, अपना आप जांच पड़ताल कराते रहिए. And to heal the esophageal mucosa, which have been damaged by the reflux of the gastric content, and you also maintain remissions for a lifetime. जैसा इलाज करते हैं, फिर हमको हो गया सप्ताह में, फिर 15 दिन हो गया, क्या इलाज कराते हैं? Is moving from doctor to doctor and from higher places also. They don't. Most important fact, manage properly and stop of complication. Our aim is not only to treat the patient, to relieve the symptoms. We have to save the patient from the complication in the future. Dyspepsia, you know already, having one or more symptoms of epigastric pain, burning, postprandial fullness, ज़्यादा खाना खाने के बाद पेट खुल जाता है. आज ये मैंने कई पेशेंट देखा कि पेट खुल जाता है, यंग लड़का है. और early satiation, कम खाए, पेट भर गया एकदम. Early satiation. So many pathophysiological mechanisms underlying functional dyspepsia symptom includes so many symptoms: delayed gastric emptying, impaired gastric accommodation to a meal. Your stomach is not accommodating the meal you are taking, depending on quantity. Hyper sensitivity to the gastric distension, Helicobacter pylori infection, you know already. Altered duodenal response to lipid or acid, abnormal duodenal motility, or central nervous system dysfunction. This also causes this GERD. Very common. This dyspepsia is very common in the community. The prevalence of excess 30% up to 40% of sufferers will consult the primary care physician. Then come to the specialist, gastroenterologist. So the epigastric pain persistent, हमेशा हो ये रहा है, तो दवा से कुछ आराम नहीं हो रहा है. ये recurrent pain occurs. Discomfort, आराम बराबर भारी पड़ रहा है कलेजा में. Discomfort centered in the upper abdomen. बोलेगा एक साथ कलेजा में होता है, heartburn, कलेजा में जलन होता है, nausea, bloating, that is fullness of abdomen, early satiety, and flatulence. These are the symptoms of dyspepsia. Choice of investigation for ulcer for dyspepsia. So in our area, when I was MBBS student or MBA student, there was a great importance was given to the clinical medicine, clinical medicine. Harrison written in his book, eye first, test second, and investigation third. Today, the newer physicians, we teach the students, they only rely on so many investigations. Previously, where खाना खाने से आराम हो गया, खाना खाने से दर्द बढ़ गया, किसी में होता है, इसलिए डॉक्टर ने पूछिए, जल्दी से आला लगाई देखिए. पेशेंट भी also aggressive हो गया बहुत. आप क्लिनिकल मेडिसिन भूल के आप चल गए एविडेंस बेस्ड मेडिसिन. यूएस एफडीए ने क्या कहा, उसको फॉलो करते हैं. So this is not fair to our community in our area. So clinical medicine should be given importance in clinical practice. As Hunter Hutchinson book, you must have read in the student area, the student life. So that should be applied, not rely on. आप लिख दीजिएगा एंडोस्कोपी विलेज एरिया में, क्या कराएगा एंडोस्कोपी? नहीं करा सकता है. So clinical sense, sign and symptoms, diagnose first upon that. This is the clinical based diagnosis of the disease. So endoscopy very expensive. Sometimes so many patients are waiting in the queue, and it creates a problem. And Also, biopsy can be done with endoscopy. Very important. Better esophagus cancer or Helicobacter pylori detection. Diagnosis of mucosal lesion, erosion, that can take endoscopy, and preferred investigation for dyspepsia. अब आइए UGI सीरीज, न्यू नेम अपर गैस्ट्रोइंटेस्टाइनल सीरीज में क्या करते हैं? This is the other name, the older name, barium meal X-ray. So contrast media is given orally, barium mostly, and X-ray, series of X-ray is taken. So erosion and other things are seen, very less expensive, very easily done by any X-ray places. EGSS usually short waiting time. अगर कैंसर मिलता है, अगर if cancer found, endoscopy will be needed. You refer to the other places. Often misses mucosal lesion, मिस कर जाता है mucosal lesion, तो endoscopy से देखेंगे, ठीक है. Alternative, especially if SS is unconcerned, आप नहीं कर सकते तब भेजिए endoscopy में. But this UGI series, this clinical based medicine का डाटा है ये. Antacid, over the counter drug, डॉक्टर इनका अल्जल पी करके आए हैं, डायजिन पी करके आए हैं, सारा पी करके आए हैं. Acids as a main, this is foundation treatment of the reflux symptoms. Acid suppression is the backbone for treating heartburn and other reflux symptoms. Patient अपने खाते रहता है, and sometimes we take too much aluminum hydroxide, magnesium trisulfate, magnesium hydroxide. So there are so many complications also, so many complications. Diarrhea, constipation, and other. With the both, taking PPI and antacid containing this aluminum hydroxide or magnesium trisulfate, this causes alkalosis. So don't prescribe concomitantly. So best better is that alginate. I am coming later on. Best is that antacid. That will coat, create a coating on the damaged mucous membrane of esophagus. So this World Gastroenterology Organization developed guideline for the community-based management of common gastrointestinal symptoms, recommending antacid, very appropriate OTC treatment. Mild, moderate symptom में और heartburn में हम देते हैं. Currently, latest now, up till now, this antacid therapy is recommended for mild gastroesophageal reflux symptom, whereas proton PPI is recommended for severe symptom, severe symptom. Recently, लेकिन हम लोग clinically और all patients prescribe PPI. Among OTC medicine, usually antacid were the most commonly chosen treatment. 85%, more than 85% patients use antacid. Now, acid pocket, very important thing. आप एक पूरा दे रहे हैं PPI का डोज बढ़ाते जा रहे हैं. एसिड पॉकेट जो है ये आपके बीमारी में ठीक होने लगा पेशेंट को. एसिड पॉकेट is physiological phenomenon that occurs in all individuals. We all, normal person also, not just those with GI reflux diseases. It occurs in normal person also. This acid pocket. The food that person takes neutralizes gastric acid, very good. But soon afterward, within 15 minutes, 15 मिनट के अंदर में क्या होता है? The stomach secretes acid in response to the food. So this, what is going to do this? Acid secrete हो रहा है ये. So this newly secreted layer of this acid layers floats on the top. Floats on the top. That has given a raft. जो लकड़ी का नौका चलाते पानी में तैरता रहता, तैर रहा ऊपर में से. On the top of the meal, जो खाना खा उसके ऊपर में तैर रहा है वो. It does not mix with the meal. खाना से नहीं मिल रहा, नहीं मिलेगा, ऊपर तैरेगा. This results in region on the top of the foot. This is known as acid pocket. Acid pocket. आपके तो ट्रीटमेंट के लिए acid pocket का ट्रीटमेंट नहीं कर रहे हैं. That is highly acidic, very highly acidic. Normally less than और अप्रोक्सीमेट 2 pH वर्ल्ड है, कितना हाईली एसिडिक है ये, किससे आप न्यूट्रलाइज कीजिएगा इसको, सेम को मिलिट्रॉन. So this is the antacid. You see the alginate, antacid mixed with alginate, that is they going to react. जो आपको सो खत्म करेगा ये अनकम्युनिकेटेड. So onset and duration of action. Fast action, relief in just 3 minutes. Long lasting relief. Action lasting relief up to the 4 hours. So this Gibson double action liquid antacid and alginate combination is more effective than antacid in controlling postprandial esophageal acid exposure that is incurred per patient. Double blind cross over study was done, and these are compared with simply antacid or mixed with the alginate. That is the product is here lying here on the table. alginate antacid plus PPI एडम थेरेपी कब देना है, शुरुआत में दे देना है कि बाद में देना है इसको. Recent systemic review has reported that breakthrough symptoms in 30 to 60% of PPI treated patients in primary care and community-based studies. In some cases, unresolved symptoms, particularly regurgitation, अब दे रहे हैं regurgitation नहीं ठीक हो रहा है, can have a significant impact on social and physical functioning, sleep quality, and missed work. रात में नींद नहीं पड़ा, सोया रहा, काम पर नहीं गया, बेचारा कमाया कैसे आपका दवाई खरीदेगा? This is a great problem. This untreated patient, acid pocket, I mentioned earlier, acid pocket forms on the top of the food, buffer gastric content, and acts as a highly acidic source of postprandial reflux. This acid pocket is responsible for the postprandial reflux. How will treat this? I'm going later on. This postprandial layer of gastric secretion also exists in PPI treated patients. Whatever is the dose of PPI you give pantoprazole, rabeprazole, omeprazole, so many doses have come in the market. I'm coming later on. इसमें होता है ये PPI दे उसके बाद ही नहीं आता. आप ही सोच रहे हैं क्या हो गया ये? So all PPI treated patient, it is less acidic. It is the less acidic than the acid pocket, but remains the source of reflux after meal. In the cause, खाना खाने के बाद भी reflux heartburn हो रहा है उसको. Alginate, what is important alginate? Antacid plus PPI add-on therapy. Alginates very important, are very interesting drug for use as an add-on therapy because they act in complementary way to PPI. Complementary दोनों दो एक साथ काम करता है by directly capping postprandial reflex. अगर आप ये alginate antacid हम देते हैं PPI के साथ, जो आपको जो acid pocket है न्यूट्रल होता है, उसको न्यूट्रल होता है. The alginate antacid formation has been shown to co-localize and eliminate the acid pocket in GERD patients. It has been found. Why did this alginate not? So this general antacid, traditional antacid. The gel-like alginate, it is gel-like, wrapped forms, जो बदला मैंने जो बेरा, wrapped form, close to the gastroesophageal junction, and is able to frequency reflux in place of gastric content. ये reflux हो जाएगा alginate gastric content के बदले में, तो relief देगा उसको. Further, recent in vitro data says that alginate may bind, not may bind, it binds. It binds the esophageal mucosa. It has got affinity for the esophageal mucosa. Alginate को, so both frame है. They stick to that, it is coating to the damaged esophageal mucosa, and this provides this mucosal protection. Again, this is alginate combined with PPI in patient with severe PPI that is not responsive to the gastrostomy reflux disease. Dose of omeprazole, pantoprazole, so many doses are there. MA or we concluded this alginate add-on therapy with PPI. What conclusion have we drawn here? Alginate antacid works by forming a mechanical barrier on the mucous membrane. The gastric content and the load of vaginal sphincter LES when exposed to gastric acid. With this ability to form a barrier, alginate antacid have found utility in controlling postprandial heartburn regurgitation. When the patient complains of it ऐसा ठीक नहीं हो रहा, अगर आप pantoprazole खिला रहे हैं 2 बार omeprazole खिला रहे हैं 40 मिलीग्राम नहीं आराम है, you add this antacid containing alginate. For patient partial response to PPI, I told you, and also alginate antacid serves as useful and very useful. 100% patient cure rate has been reported all over the world. Efficacy of alginate based reflux suppressant and magnesium aluminum antacid gel for treatment of heartburn in pregnancy. In pregnancy, mostly in the last trimester of pregnancy, the pregnant lady complains in the last trimester, but it occurs in any trimester of pregnancy because progesterone level is high during pregnancy. This causes also physical mucous erosion. And patient lady complains of heartburn, जलन होता है. So PPI and other antacid, other PPI or H2 receptor blocking जो आप लिखते हैं उसमें तो placental barrier से पास करेगा, just cause them to the fetus also. So best is antacid containing alginate must be tried. I will not go into detail of that. मेगालेट तो पहले से हम लोग लिख रहे हैं, अभी आया अल्जीनेट. मेगालेट इज मैग्नीशियम एल्युमिनियम मोनोहाइड्रेट, not magnesium triacetate or hydroxide. It is chemical bonding, not just mixing magnesium hydroxide and aluminum hydroxide. That magnesium triacetate, that causes complication or diarrhea. Megalate is a complex hydroxy magnesium aluminate. But क्या करता है? It reacts with HCl. And ammonium hydroxide is released. Ammonium hydroxide reacts slowly with acid and gives a sustained effect. Thus, it has got benefit of both ammonium hydroxide sustained action and magnesium hydroxide rapid action. In addition, it may neutralize side effects. Not may neutralize, it neutralizes. The magnesium hydroxide causes no diarrhea. Aluminum hydroxide causes constipation, so both are balanced. Both are constipating and diarrhea causing antacids are both combined, so it is balanced. It is not complaint of diarrhea or constipation. You know already. So when megalate we prescribe, what indication of megalate? This antacid is prescribed in supplementary relief of peptic ulcer, gastritis, that is inflammation of the stomach mucous membrane. Also, there is inflammation of the esophageal mucous membrane, hiatus hernia, another dyspeptic condition associated with hyperacidity. Hyperacidity, क्या concern? I have mentioned so many. Megalate versus other antacid. How megalate scores over other antacid? So, like other antacid, megalate stimulates endogenous prostaglandin E2 synthesis in the gastric mucosa, and this causes healing of the gastric mucosa. Megalate has a higher capacity than neutralizing acid as compared to the magnesium triacetate. Magnesium triacetate outdated हो गया है मेरे triacetate aluminum hydroxide. Simethicone, so many antacid producing company की हम simethicone है, ये है हमारे गाते हैं. Number 1. Simethicone is an oral anti-gas, anti-fluorescent medication, anti-foaming agent which reduces bloating, discomfort and pain caused by excess gas in the GI. साइमेटिकॉन भी बोल रहे हैं, अल्जीनेट भी बोल रहे हैं, दोनों में क्या डिफरेंस है? दिस causes this type of symptom relief. But alginetes form a coating of the mucous membrane. It also neutralizes acid pocket also. This is the difference between the two. Now come to a drug therapy. एक तो वाले बहुत प्रिस्क्राइब कर रहे हैं, साइमेटिडीन तो जस्ट बैंड हो गया, उसे नाम बोलने के लिए लग गया किताब में. This is the main treatment for mild to moderate GERD. हम लोग के समय जब फाइनल ईयर के एग्जाम में बात इसमें आ गया था, ये जो भाई पूछा गया था सर्जरी में किसका क्या डोज है, क्या साइड इफेक्ट है. So this is equally effective. How select based on pharmacokinetic safety profile and cost. हमको सिलेक्ट करना है वेरी इकोनॉमिकल, क्या टाइमिंग, इसको क्या करना है. सेफ्टी प्रोफाइल इज नॉट so much safety as compared to PPI. You know that the side effect of this H2R receptor. Timing very important. It should be given in divided dosage for constant gastric acid suppression, because plasma half life of H2R receptor antagonist, जो आप लिखते हैं एंटीफाइमेटिडिन, only 8 to 6 to 8 hours only. That's 2 times given. As compared to PPI, which got half life more than 24 hours. I'm coming later on. It gives at night. It is given at night if only noxious symptom. रात में अगर symptom होता है तो रात में दीजिए. Give before an acidity that may result reflux symptom. Reflux symptom से भी उसको जाके दीजिए. Not for the long period of time. This is the low dose and high dose, you know already. Samidine only for this study, not available or not prescribed with side effect. The standard dose you know already. H2RA depends upon severity of disease, duration of therapy, dose regimen, tolerance of the patient. Now come to the important part in this chapter, proton inhibitor. It is used to treat moderate to severe GERD, more effective and faster healing than H2RA. It may be used to treat esophagitis restricted to H2RA. Maybe not. It is used. It should be used. Not maybe used. It should be used. H2RA. All agents are effective. Don't go in this check review of omeprazole अच्छा है, esomeprazole अच्छा है, metronidazole अच्छा है, letrozole अच्छा है. These are market gimmicks. All have the same mode of action. All reduces the acid secretion and neutralizes the acid, but they only differ in the pharmacokinetic profile. Pharmacodynamically, all PPI are same, but pharmacokinetic differs. Its absorption, its selectivity to the proton pump, duration of action, plasma half-life only differs. That is, this letrozole is scored for all this PPI. I am coming later on. इसलिए मार्केट नहीं जाएगी ये अच्छा है हमारा अच्छा है, कुछ नहीं है. All have got the same word. Only pharmacokinetic profile differs. All agents are equally effective. Dynamically. Dosing you already know. I'm not going to detail of esomeprazole, letrozole, omeprazole, metronidazole, letrozole, dexlansoprazole. बहुत हंगामा की हुआ कि मेरा dextrorotatory, levorotatory, CS को यहाँ बेंजीन में डाल दिया था, dextrorotatory हो गया, बहुत effective. These are the dilemma to the patient also. Best, it is very best to give 30 minutes or 1 hour prior to breakfast. Why why not after meal? Why? Because you know that it is very absorbed very rapidly. They will block at the proton pump very rapidly, and your steady plasma concentration is 100%. If you take after meal, what will happen? Bile will be only 50%, 30 to 40, 50%. It should be given half an hour, preferably 1 hour before before the food to have the better concentration of the drug that will immediately block the proton pumps. Sometimes patient are complaining that a ठीक नहीं हो रहा है, बहुत आराम नहीं देती. You may we prescribe higher dosage BID for कहाँ देंगे BID? वो जो देखते हैं पूजा आता है आप लोग के पास डॉक्टर से 2 बार लिखवा 3 बार लिखवा. The patient which has got partial response to standard therapy. अब आया खा करके वहाँ से ओमेप्राजोल के हाथ से आपके पास आया, ठीक है, ओमेप्राजोल 20 मिलीग्राम प्राइस दे सकते हैं, 40 मिलीग्राम से दे सकते हैं. पेशेंट विद ब्रेक थ्रू सिम्टम्स, कभी हुआ फिर ब्रेक थ्रू हुआ, फिर हो गया फिर नहीं हुआ. पेशेंट विद सीवियर स्पेशल डिसमोबिलिटी, severe dismobility symptoms patient has got, and patient with Barrett's esophagus, I have told you, very pre-cancerous stage, later on conversion of esophageal carcinoma. Second dose should always be given 30 minutes prior to the evening meal. Evening meal, I suggest the World Health Organization and all the gastroenterologists of the world that meal should be taken 4 hours before bedtime. सामने में खाना, सब नहाता लोग पहले सामने में सूर्यास्त के पहले खाना खाना. This is the best treatment, preventive treatment for the GERD. So always give second dose 30 minutes prior to the evening meal. Evening meal कहा, नाइट मील नहीं करा, इवनिंग में खाना है आपको. जो पेशेंट पॉसिबल नहीं है, हम लोग भी अपने रात में 10 बजे खाइएगा. अब इतना मार्केट गिमिक्स है, इतना जंगल है पीपीआई का, कैसे हम चूज करेंगे? इट डिपेंड्स ऑन द फिजिशियन कैलिबर एंड फिजिशियन नॉलेज एंड फिजिशियन क्लिनिकल सेंस. हाउ विल चूज पीपीआई ट्रीटमेंट ओवर अनदर, व्हिच वन इज बेटर? सो यू शो दैट डिसेंडिंग ऑर्डर में देख लिया, खांसी में कैसे ओमेप्राजोल आया, लेंसोप्राजोल आया, पेंटोप्राजोल आया, अरिप्राजोल आया, एल्प्राजोल आया, डेक्स लेंसोप्राजोल हंगामा की हुआ, आपको आता हुआ कि बहुत अच्छा है. So these are the, I have told you, these are the market gimmicks to take the maximum market share from by the doctors from the market. All have got the same pharmacodynamic profile. I have told already. PK, you know that it refers to the degree of willingness of compound to accept or donate a proton. This compound with pK of 5 pK should be, जो कि एलेप्राजोल का लेटर बना रहा है कि 5 से ज़्यादा है उसका, 5 के करीब है. 5 जिसका pK है, जिस PPI का, 10 times more basic than the compound with pK 4. जिसका pK 4 है, उससे नीचे है, तो 10 गुना ज़्यादा होता है इसका pK 5 है. तो जो आप जो वर्ल्ड का मैंने स्टडी है, so many trials of eleprazole, they have got 5, I think 10-fold more efficacy than other PPI. This is eleprazole. So you see that PK, this is 4.53. This is your old data. Now it has become 5.83. 5.83. This should be corrected. PK of eleprazole, not this. कितना आपका पेंटोप्राजोल का है 3.83 है ना. पेंटोप्राजोल ज़्यादा प्रिस्क्राइब होता है, लिबोरेटरी कंपाउंड है उसका ज़्यादा है. तो दिस इज एप्राजोल स्कोर्स ओवर ऑल द एंटासिड एट दिस. तो हायर पीके का इंपॉर्टेंस है, क्या जरूरत है हायर पीके का? ए ग्रेटर एक्युमुलेशन इन द पैटल सेल अनदर प्रोटोन इनहिबिटर, बिकॉज दिस एप्राजोल स्टेज मोर period of time, length of time in the proton pump. आप प्रोटॉन पंप से सिर निकालिएगा, आप पहले से आप वहाँ तैयार हैं, बैठे हुए हैं 24 घंटा ज़्यादा. एप्राजोल ओनली. So this is the importance of PPA. A greater accumulation of the fatal cell than other proton inhibitors developed all over the world. So PPI mode of action, I will not go into detail of that, you know already how it blocks. You see that eleprazole market, this is marked acid inhibition. Eleprazole 100% inhibition. कितना देर में? Only 5 minutes. 5 minutes. Lesoprostol 66%, pantoprazole 20%, 20% not, it is now 35%. The old data. Omeprazole 47%. So this ceftriaxone scores over all the PPI in acid inhibition. Single dose pantoprazole दिए, single dose 40 milligram फलाना दिए थे, कैसे केस हुआ? Single dose of rebrazole, this trial data and graph shows single first dose of rebrazole inhibits acid 100%. First dose, ऐसा नहीं पantoprazole 3-4 दिन खाएगा तब आराम होगा, या दूसरा खाएगा ऐसा नहीं. This gives all the data and trial shows. So this concludes that in GERD patient with nocturnal heartburn, rebrazole 20 mg significantly more effective than pantoprazole 40 mg. In percentage time with integrative pH more than 4 more than 4. At the night time and daytime and 24 hours period, then 24 hours. Rebrazole works for 1 tablet works for 24 hours. Should not be given twice daily. Difference between treatment of OAE we are not demonstrated. This trial is going on. I will not go into detail the copridogrel we describe in the post-maker infarction or to prevention of the maker infarction. This should be given. This should be given. It is helpful. It increases the efficacy of copridogrel, anticoagulant. Rebrazole also has got the power to secrete more mucus. Other PPI not, I have reported receiving Uniquely increases mucus production by gastric mucus cells. Very protection, there is no protection against mucus secretion. And this additional mechanism that you also promote ulcer healing. Other PPI do not share this property. Rebrazole has got mucus production and this promotes ulcer healing.
हम यही लिखते हैं,
हाँ अब बताए थे.
सबसे चलता यही है.
This has been found by so many trials that
इसका नाम
this rebrazole also increases mucin content.
सायरा डी.
Prokinetic. बहुत हम लोग आपके लोग लिखे होंगे prokinetic. In GERD में क्या importance? Whether it has got any role or not, prokinetic. So of the upper GI disease, GERD is an acid-related disease that remarkably reduces the quality of life. PPI is the first choice regimen for GERD. Now, most of the PPI receptive patients respond to prokinetic. PPI is unstable at low pH. Retention of PPI inside the stomach for a long period of time. This results in an impaired acid suppressive effect. So rapid transit of the PPI to the upper intestine will be of benefit. This PPI have central role in the initial treatment approach I told you already. What is the use of prokinetic? Its use is based on the assumption that upper gut hypermotility is a common pathogenic factor of dysphagia. So it increases specialty movement. Prokinetic also facilitates coordination of peristalsis movement in the GI tract. Also, this prokinetic facilitates the passage of acid content from the stomach to the duodenum. Prokinetic nowadays so many side effects, cardiac side effects are not we are prescribing. So where is the era of metoclopramide and levosulfuride, whether it is patient compliance, tolerability, this comparison study in patients with non-ulcer functional dyspepsia. A comparative analysis has been done and the conclusion is that इस रेंडमाइज्ड ट्रायल में लेवोसेल्प्राइड, डोमपेडोन and metoclopramide in functional dysphagia trial was done, and you see that overall dysphagic symptoms relief rates were significantly higher in the levosulfide group. You see the levosulfide group in the blue graph bar as compared to the domperidone and metoclopramide. Levosulfide very effective, though it is an antipsychotic drug used in the high dosage in schizophrenia and manic disorder, panic disorder, negative positive symptoms, so many symptoms. But this levosulfide contains all the things. एक से दो चीज पाते हैं आप, एक खरीदिए दो चीज पाइए, दो शब्द देता है। एक तो आपको बेस्ट प्रोकाइनेटिक काम कर रहा है ये, दूसरा also सीरियस दी पेशेंट, उसमें आपको कोई भी ट्रैंक्विलाइजर या सीरियस देने की जरूरत नहीं है। Then you add the levosulfide, the patient also comes, जो ट्रीटमेंट हम बताएं गट का उसमें है कि योगा एंड मेडिटेशन करा लेता है। तो levosulfide scores on all the metoclopramide and this domperidone. Just for the side effect, you know that already. So chronic administration of levosulfide and glycemic control in IDDM patient and gastroparesis very effective in diabetic gastroparesis. You must be seeing the patient of constipation diabetic patient उसमें देते हैं. I will not go in detail. What you conclude with this study, so many trials and studies. Results support that the role of peptide in maintaining glycemic control in IDDM per subject. Levosulfide constitutes a safe therapeutic option for the chronic treatment of diabetic patients with dyspeptic symptom and delayed gastric time. उस जमाने गैस्ट्रिक पैरालिसिस में हम लोग डायबिटिक पेशेंट को यूरोसोमाइसिन पढ़ाते हुए थे कि हाई डोज में देना है, 1 ग्राम 4 टाइम डेली देना है. This is the best drug, levosulfide. So levogastrochronic effect of levosulfide in dyspeptic patient with diabetic gastroparesis. I will know with detail. What we recommend? What are the recommendation by the gastroenterologist? Role of prokinetic protein inhibitor, combination in functional dyspepsia and GERD. Recommendation क्या है ये? Additional prokinetic to PPI to inhibit proton pump is recommended. किसमें देना है? In the non-erosive reflux disease. When erosion is not there. Patient with a strong dysmotility and functional dyspepsia. Recommendation in non-erosive reflux disease patient with a strong dysmotility and functional dyspepsia. क्या करते हैं उसमें? Initially PPI therapy, PPI effective, continued PPI. कितना देर देना है? कितना देर खाएंगे? 6 सप्ताह, 8 सप्ताह, साल, 2 साल, जिंदगी भर. Whole life it can be taken. If there is no need.
Vitamin B12 taken.
5 years
Potassium.
to 7 years, I have seen no patient has complained that vitamin B12 deficiency or dysphagia or mouth or other things. So these are the side effects of. For the longer period of time, which PPI is more suitable? Pantoprazole is scored for all these. Pantoprazole does not cause any adverse effect. In longer period of time, we use. 15 दिन में लिख दिया फिर आएगा माथा फोड़ने आप कहाँ तक ठीक हो गया खाते रहिए मतलब DIT ट्रैक आई तो उसको फिर कराते रहिए DM गैस्ट्रो से इफेक्टिव ठीक है PPI रिफ्रैक्ट नहीं काम कर रहा है तो क्या कीजिएगा ऐड प्रोकाइनेटिक टू PPI. Prokinetic best is levosulfide, I have told you. Non-erosive reflux dyspepsia in Asia में क्या देना है? क्या recommend करते हैं? This is recommended first choice treatment in administration of PPI in combination with prokinetic agent. ठीक है, वही चीज repeat कर रहा है. Don't go into detail. So to conclude the session, what the message take home? क्या हमने प्राप्त किया है, आप सब लोग जानते ही थे। इससे ये प्राप्त हुआ कि आप अगर फोटोमीटर दे रहे हैं, कोई भी आप चूज कर सकते हैं, लेकिन so many data and trials have shown that gradual scores over all the PPI, because the more it has got more rapid onset of HKATPase inhibition, as compared to other PPI. It has got greater effect in reducing इंटागैस्ट्रिक पीएच को बढ़ाता है, करता है। ड्रग इंटरेक्शन सभी पीपीआई से होता है, very less or negligible drug interaction जो है reported all over the world. It is more potent acid inhibition, more potent acid inhibition because it got more affinity and sustained for longer period of time in the proton pump, retrazole. So more rapid onset of action starts with the first dose of the drug within 5 minutes, and this reduces gastric pH, acidity, this reduces acidity, acid secretion as compared to all PPI. So all the things, but other thing is that सारा चीज होने के बाद भी आपका जो नहीं आराम हो रहा, बहुत जगह दिखलाया, मैदान कहीं भी गया तो नहीं आराम हो तो क्या कीजिएगा उसको, क्या बताइएगा उसको, क्या करना है, आप लोग सर्च कीजिए होम रेमेडी। भाई इसलिए करना परहेज क्या कर रहे, परहेज पूछता है ना आप लोगों से, परहेज क्या करना है। नंबर 1, द पेशेंट overweight, reduce the weight, complete cessation of smoking and alcohol, complete stop the smoking, not only for good, other you know already. No tight dressing should be applied to the patient. Don't wear the loose dresses when you are having GERD symptoms. No spicy food, तीता मीठा मसाला देखते होंगे पेशेंट को, नो स्पाइसी, नो फूड कंटेनिंग द एक्सेस ऑफ फैट should be advised, and कोल्ड ड्रिंक रिलैक्स है पीने के लिए, स्प्राइट हमने नहीं किया, कोल्ड ड्रिंक कार्बोनेटिंग शुड बी अवॉइडेड, इंक्रीजेज GERD, जो पीता है झेका हो जाएगा, जल्दी निकल जाएगा, बेल्चिंग पे कोई जरूरत नहीं है, आप लोगों से पैर क्या देना हो जाएगा। You must change the dietary habits, पूरा भरपेट खा लिए, जल्दी कम में खाते पेट भर जाता है, बेल्चिंग फुलने में पहले से डाइटिंग नहीं होगा, थोड़ा मीट थोड़ा सा देर खाइए, खाली पेट ज़्यादा नहीं रहिए, बताते हैं डाइटिंग चेंजेस। ड्रिंक एक्सेस क्वांटिटी ऑफ वाटर, बहुत पेशाब है कोई बात जाते रहिए, पानी ज़्यादा लेंगे, बिकॉज दिस न्यूट्रलाइजेज, दिस ऑल्सो एसिड ऑल्सो, इसलिए पानी खूब पीजिए। जैसा दूध पिएंगे पूछता है ना, दूध पीते तो गैस बन जाता है, should not be advised. The fat containing milk should not be advised to the patient because it increases GERD. Fat-free milk should be advised to the patient. You want to take the milk, ताकत के लिए fat-free milk should be advised. Stop eating 3 hours before the bedtime. 3 घंटा पहले आप ले लीजिए, 3 घंटा पहले आप जो है सो खाना खा लीजिए बिफोर आपके सो जाने पहले। दूध नॉन फैट मिलेगा नहीं यहाँ, तो आप तो दिल्ली मुंबई में रहे हैं, एकदम सब यहाँ सुधा का दूध मिल पी रहा है, मिलता नॉन फैट बेचता है, वहाँ मक्खन निकाल लेता है, हम लोग उत्तर देहात में मिलता है, तो पिछले से क्या करता है, क्या काम करता है, क्या करता है, दिस एक्ट्स एज ए बफर, जो बताया आपको सारा चीज निकालते हैं, it acts as a buffer. This gives immediate relief from the hot for the patient. So thank you very much for your patience hearing. I have spoken too much. There was 89 slides. कितना है? 89 है जी? Yes sir. These are the references. So thank you very much.